Morning, everyone. I want to praise and reward because I'm a behaviorist. So anyone who actually got here, woke up, had breakfast, and got here gets rewarded. Because I'm going to just first ask. So Gretchen always asks me to talk about 3 or 4 or 5 different things. Today she asked me to talk about autism, neurodevelopmental neuropsych testing, and IEPs and accessing school services, all in 45 minutes. So I'm willing to take questions right now, burning questions from the audience that you want answered. I don't know if I can answer them. But you can ask now or you can ask as we go along. I mean, I'm so glad to see some people here with very young children. I geared this talk towards those with young children who haven't quite been through the system, but I know that there are some people with older individuals here that probably could give this talk better than I can, but I did want to gear it to families just starting out on this journey. So I'm going to try to talk about 4 different things. So I'm really not going to actually spend too much time talking about autism today, but I can talk about it to anyone, anytime. I don't think we need to overemphasize autism, so I don't want to do that. But then I'm also going to focus on a little bit about what we do with neuropsych assessments. I know some of you know firsthand. And then I'm really going to try to focus on IEPs and the big picture to make sure that people understand the rules, and then really what you can do from all the testing your kids do to help maximize IEPs. So in terms of autism, just making sure everyone is aware of what actually is written as the criteria. The criteria for autism, there are 1, 2, 3, 4, 5 of them actually, and they're all equally important, and so I want to just go over them really quickly. So for a diagnosis of autism in the DSM-5, which is the current version that we're using, there needs to be persistent deficits in social communication and social interaction across contexts that are not accounted for by developmental delays, and that are manifest as deficits in social reciprocity, the back and forth, nonverbal communication, so not about language, but about compensating with nonverbal communication like facial expressions, gestures, and deficits in developing and maintaining relationships. Well, I think a lot of you will probably say that your children have these things, but the most important thing about autism is that these deficits are beyond the developmental delays that the child has. And I'll talk about how we try to account for that in a minute. And then along with that, there needs to be the presence of restricted, repetitive patterns of interest that are at least stereotyped or repetitive speech, motor movements, or use of objects, so doing things over and over again, either with your hands or body, or with objects, or with what comes out of your mouth. Then insistence on sameness, inflexible adherence to routines, ritualized patterns of behavior, as well as highly restricted, fixated interests that are abnormal in how intense they are, and then hyper or hypo, or both, sensory input in relation to the environment. So again, you might say you see a lot of these things too, but a lot of these things are also present in individuals with developmental delays as well. And the restricted interest needs to be not just limited by what the child is able to do, but actually restricted from what they can do. And then the symptoms have to be present early in development, and then they have to be clinically impairing, functioning, again, beyond what a developmental delay would do. And then the last one is actually the criterion of what I've been talking about already, which is that these disturbances have to not be explained by the intellectual disability or developmental delay. And oftentimes in SLO, they are. So I'll just say that most of you know who I am because we've met before, but for those who don't, in my job at NIH, I've been the one conducting the neurodevelopmental assessments of children with SLO for 15 years almost. So I'm speaking not from just theoretically about SLO, but from having been testing a lot of the kids and adults. So DSM diagnosis of autism is a single spectrum. It is a single diagnosis now. There isn't a diagnosis of Asperger's anymore or a pervasive developmental disorder. It's just a diagnosis of autism spectrum disorder. But within that diagnosis, there can be a real huge variability in how severe the autism symptoms are, what the pattern of onset is, and how the clinical course is, what the cause is. That's the etiologic factors as the cause. Or associated conditions, and then again, what a child's individual strengths and weaknesses are. So if your child does get a diagnosis of autism, that it isn't just that, it should be explained by all the things I'm talking about. It isn't just one word autism and that's it. There should be a description. But all the symptoms I just talked about that define autism are one thing, but then many individuals with autism also have a variety of the outer circle conditions that are listed here, and some of them may be very, very familiar to you as well. Standing out here, is ADHD or hyperactivity, as well as tics and even more pervasive sensory integration issues, auditory processing, and I just want to show that those things are also extremely common in SLO, with or without autism. So we know that. And then again, if there is a diagnosis of autism, it needs to be put into the context of the child. So on the left here are the criteria that I just described, the social emotional reciprocity deficits, the nonverbal social communication deficits, all those things that I just described, but they need to be put into context of the child's language level, their intellectual functioning, their adaptive behavior, sort of what they're really doing in the real world, and all the comorbid symptoms and medical conditions that the child has. So again, autism should not be, the big only thing. It should be in the context of where the child is. And so because of that, the DSM made specifiers that should be described for every child. And again, that includes whether there's a language impairment, which is often the case in SLO, as well as intellectual impairment, and then whether it's associated with other mental conditions, which would be something like ADHD or OCD, and then again, whether it's specified to be associated with a known medical or genetic condition. So in this case, SLO would be listed for the child. So autism is still mostly diagnosed over the age of 3, no matter what. I would say that in SLO, we actually would often err on the side of diagnosing it older, not because we're not seeing these things, but because we need to tease out whether it is the general developmental delay or the autism. And a really big indicator that I'll say again in a minute is that the tests that were designed to diagnose autism were designed for kids mostly who talk and definitely who walk. So if your child is not walking yet, those tests are not even applicable at all. The kids should not be taking those tests if they're not walking. So it really, we still need to work better at making tests that can differentiate autism in populations like SLO, where walking and motor development is lagging. So again, in some populations we can make diagnoses when kids are 2 pretty well, but again, with SLO we would err on the side of doing it later. So most frequently it's just language delays that bring a child in for a diagnosis of autism. So why is diagnosing autism so complicated? Of course, we're basing it only on behavior as opposed to something like SLO, which you have blood tests and genetic tests for. And obviously, we can't get self-report very often, at least in young people, to be able to help inform our diagnoses. It's you, the parents, that we're relying on, of course, bless you, in conjunction with observing the child. However, those of you who've been in a neurodevelopmental clinic know it is not home, it is not school, it is a very different setting, and so we need to be really careful because we know that kids are not going to always behave their best in our clinic. So in the real world, if I could, I would go to kids' schools and I would take time and do it over a period of time. So just so you know, what we think, we meaning research has shown that to make the best diagnosis of autism, you need to have a pretty comprehensive assessment. So it needs to start with a cognitive assessment. I keep talking about how we need to relate our symptoms in relation to the child's cognitive or intellectual level. You can't do that unless you actually know it, so you need to take IQ tests. And we'll talk about the limitations of those in a minute. You need to somehow measure, get a sense of a child's adaptive behavior, what they're really doing in the world. And oftentimes that's me asking a million questions to the parents about what the child's actually doing. Are they actually going on the toilet? Not just could they, but do they? And are they actually going out and playing with friends? And when they do, are they turn taking? Or are they doing things like that? So that comes from parent history, which includes the early development as well, and then direct observation. So for the parent history, we have a tool called the Autism Diagnostic Interview. And for the direct observation, we have a tool called the Autism Diagnostic Observation Schedule. So this is just for you to know in talking to other people too, if they're going to go out somewhere and get an autism diagnostic evaluation. These are not the only tests, but it should include the elements that I'm describing here, which are the cognitive assessment, the adaptive behavior, parent history, and direct observation. A diagnosis of autism cannot be made in 20 minutes in an office. It needs to take this much time. So as I just stated, our limitations here is that these measures were not developed for non-walkers or even just unstable walkers. They were developed for kids who have the motor skills to be able to move around, grab toys, bring them, share them, use gestures, and have sort of high-level play. So it's really unfair when we give these tests to kids who don't have those skills. Then they're getting sort of double negatives, and they're looking like they have the diagnosis when they may not. It also isn't appropriate for children with mental ages below 18 months. So kids who don't have any words, who are also not able to manipulate puzzles and things like that at an 18-month level. And also for children with significant behavior problems. If you're going to be, throwing everything or biting yourself the whole time, it isn't fair to conduct the evaluation with a child like that either. So this is one of the more commonly used instruments for screening for autism. And as you can see, many times with families, I will hand it to them and then take it right back when we realize that the child isn't talking. Because as you can see, some of the questions here are just not appropriate. Seems self-confident when interacting, is able to communicate his or her feelings to others. So these require language, and it just isn't fair. And these are actually even the items that are relevant for 3 and 4-year-olds. So, is not coordinated. Well, that isn't about autism, so it definitely penalizes populations where there isn't good coordination. So you can see what I'm saying. Our measures are not great, and we are working on it. I never put up the diagnostic criteria for autism, putting up the diagnostic criteria for intellectual disability, which doesn't get talked about as much. So I want to make sure that people know what the criteria are for intellectual disability. And there are 3 criteria for diagnosis of intellectual disability, and one of them is having deficits in intellectual functions. So things like problem solving, so puzzles, cups together for a young child, for an older person, being able to match things, sort things, make decisions. Abstract thinking, so concepts like, how are blue and red alike? They're both colors. How are a mountain and a lake alike? So really thinking more in language terms, semantics, and then academic learning and learning from experience. So actually, you don't actually need the testing to get a diagnosis. You do need it confirmed. At some point, you need to have IQ testing to establish the diagnosis. And then more importantly than how you do on these tests is the adaptive behavior that I have already mentioned a few times, which is that out in the real world, you're actually not able to function in things like socialization, being able to play with other kids, being able to go out, and about when you're older, and being able to perform daily living functions, being able to help in the house. If you're a young child, clean up. If you're older, help cooking and cleaning and things like that. These are actually the things that we use to make the diagnosis, because this is what's important, not how you do on tests. And again, for intellectual disability, the onset has to be in the developmental period. So the diagnosis of global developmental delay, it gets confusing, but you hear a developmental delay as a diagnosis. We use that for kids under 5, where we're just not sure because our tests are not terribly stable for preschoolers, and we're also looking for early intervention to alleviate these problems, so we don't often diagnose intellectual disability until a child is 5. But at that point, we change it. So then within intellectual disability, there are 4 main ranges, levels, and these do each have their own codes to them, so I want to make sure that everyone understands. These are still, right now, what I'm showing you is based on IQ level, but we changed that, and it should be based on adaptive behavior, but we haven't actually operationalized it. But in terms of what a child is actually doing and functioning, it ranges from just needing a little bit of help in functions of daily life for mild ID, to having some noticeable delays for moderate, being able to complete some self-care activities, still traveling alone, but needing help, to severe, where you need direct supervision all the time, to profound, where you're really not capable of any independent living and you need someone one-on-one with you all the time. So it's really important that we think about those. So I'm just showing, this is the only data I'm showing to show that we actually have been able to get IQ testing on pretty much every patient we've with Smith-Lemli-Opitz, and that we know that when you're in there in the testing room, that it feels like, are you really getting the best for my child? Do these tests really actually show something? We often have to use tests that are not the test that is designed for the age range, but we've made a structured way of deciding which tests to use for a child based on the functioning that we see when they come in. We have been able to get IQ tests, and we think that these IQ tests are valid for a lot of reasons, because they often match what we see from schools and the outside, but also because we actually were able to find a very significant correlation with 7-dehydroxylase and 8-dehydroxylase, actually both from CSF and blood, which tells us that something about the biomarkers are relating to their actual functioning. So I just wanted to make sure that everyone knew that those findings are out there. So why do we care about any of these diagnoses at all? Is because we want to get intervention for the child, and we want it to start as early as possible. So you shouldn't need all the diagnoses we're talking about to get the early intervention when the child is below 3. All you need are a few scores that show that the child is at least 1.5 or 2 standard deviations below the mean on any single skill. So that could just be language, it could just be motor. You just need to get some scores that show the delay. And the early intervention in this country should be coming into your house and performing the testing themselves, so you shouldn't need to go out at that point. So again, why we care about assessment at all is to get these things as early as possible. Hopefully medications will not be so early, but behavior therapy, education services, and other therapies, that would be part of an IFSP. So I just want to make sure it's understood, because our reports can be very confusing and long, and you just want to see what you want to see. You don't want to go through it all. But what we always do when we do neurodevelopmental testing is give some background. If the child's had 10 surgeries, we probably want to put that in there. If they were in the hospital for a long period of time, and what medications they're on, if they have seizures, things like that. Then we always put in some observations of the child, because that contextualizes the findings. Again, if the child was throwing things the whole time, that we know that the testing might not be as valid, or what we needed to do to improve the situation so that the child would perform best, whether it be handing out food or rewards or taking lots of breaks. We always provide the test results. and then the summary, which should contain diagnoses. So we don't highlight the diagnoses because they're not the most important thing, but we always do want to put them in there. And then we always try to translate these into recommendations for IEPs. So I think I've said all this already. So now moving into to what the real world, at least in this country, requires, and the structure for moving into services is the Individuals with Disabilities Education Act, which is really important in that it really established having free and appropriate public education to meet the needs of every child. And so what we start with here is Part C for those who have children still under 3. Part C is recognizing the need to identify and help children as young as possible. So it's not called an IEP when children are under 3, it's called an IFSP, an Individualized Family Service Plan, and that's because the family should be the sort of owners and very involved in the intervention at that point. And the families not only have the right to participate in these service provisions, but also to help develop them, not just when they're young, but all the time should be at the table in helping develop the service plan. And then if they're not in sync with the rest of the team, they should have the right to continue to work on it until they're satisfied. So again, it's based on U.S. public law, and it really emphasizes the large role of family involvement. So early intervention is the result then of Part C in terms of educating children with developmental delays in families. So again, as I said, it can be delays in physical, cognitive, communication, social, emotional development. It doesn't have to be all of them where services can be provided. And again, it's to help get services as soon as possible. So often the targets of the intervention, clearly speech is a major one, and we're going to hear in a few minutes about speech and alternative ways of communicating. Imitation is a skill that doesn't get talked about so much, but is the basis of learning. And for a lot of children with developmental delays, it just doesn't come naturally. So imitation is something that the early intervention providers can really target themselves, but also teach you ways to elicit it. And this goes even throughout life, is that still teaching a child how to imitate and praising them for imitation and furthering attempts at imitation of appropriate behavior and, of course, play as well as language can continue to help improve a child's functioning throughout life. Of course, social engagement is necessary for these things, so there are ways of teaching parents and family and others to help improve social engagement by praising, rewarding, elongating back and forth with the child. Joint attention is essential of having the child be able to pay attention to the same object or toy or thing that you are. And pointing is a huge skill that can help with that. And then play skills, which people think maybe are not that important, but they are so essential. Continuing to play, teaching play skills is how language is learned. It's how we learn so many things, and those things can continue. We don't have to memorize this. There's just so many different methods out there. Applied behavior analysis is an umbrella term used for a lot of the methods that are used, and it really is not a specific thing, so I didn't put a definition there for that. It's really the approach of using behavioral strategies, basically rewarding a child, being specific about what you're teaching in a therapeutic session, in everyday life, in school, and so I don't want people to get scared by that term or think it's not appropriate for them. And so the others are actually, some of them are sort of subunits of ABA, others are different approaches that you may have heard of, so we just wanted to put them out there. The myth about ABA, there are many myths about it, but one of them is that it's only for kids with autism. So I put up this website from Kennedy Krieger that really has some references on it about how it is not just for autism. So again, the overemphasis about autism and getting a diagnosis of autism is really about getting services. And I'm here to say that with or without that autism diagnosis, many of these services can be very helpful for children. The targets of ABA can be to decrease problem behavior, as well as teach language and many other skills. So things that report recommendations can be used for IEPs for early intervention would be, I'm just giving you examples of things that would be helpful from reports to bring to IEPs and to the IFSP for kids would be things like increasing the ability to sit at a table and do work, understanding the difference between work and playtime, being able to intersperse non-preferred activities, which are the work, which are the harder tasks that the child is learning, with more preferred activities that the child wants to do. And using things like movement and music to have breaks, but actually be helpful breaks because they're helping the child learn in other ways. So then in terms of the flow of how it goes in early intervention, the referral should come from a pediatrician, but often doesn't. Parents have to take it upon themselves oftentimes to make the referral to initiate the services. And then there should be a service coordinator who helps. There's an evaluation, there's an IFSP, the early intervention occurs, there should be a review every 6 months, and then when the child is 3, they transition to the school system, which is Part B, which is the Individuals with Disabilities Education Act really comes in with Part B. And that should really happen before the child's third birthday so that things are in place to move when the child turns 3. So the differences between an IFSP and an IEP are certainly the age that it's being used. And again, the emphasis on families. Families do not become not important when the child is 3, but they're really essential to the IFSP before 3 because these services are occurring in the house and the families should be integrally involved. When it's an IEP, it becomes once a year for review instead of every 6 months. And the IEP team makes decisions once it's an IEP, but parents are supposed to be part of that team. So I brought with me this book, which I think a lot of parents have found really helpful. I'm not advocating for any particular book, but there are many books out there, especially relating to the rights law website, which is free, but many resources out there to help families through this process throughout the lifespan, because it is a lot with lots of different nuances and laws that parents are not all lawyers, and even if they were, there's so many specifics to help prepare and be able to implement the best IEP for the child. And of course, services are different by states to state. But again, books like these have chapters for preparing for meetings, for what you need to know beforehand, creating paper trails so that if services are not being administered the way you want, you can make changes, and then the due process when things are not going the way you want, what can be done, what you can do to make changes. So again, IEPs are really only renewed or updated once a year. Having said that, you as a parent are allowed to call and ask for an IEP meeting anytime you want if you're not satisfied with the services or there just needs to be a change. There's supposed to be a very large review that happens every 3 years. And just so you know, there are 13 categories that are defined that a child is placed under in an IEP. So these are the categories, and it's really important to know that they do not need to match the medical diagnosis of the child. As you see, SLO is not up there, so it wouldn't be one. SLO on its own would place you in other health impaired. What? No, just the diagnosis of SLO would put you under other impaired, you would need to establish a diagnosis of intellectual disability to have that be added. And then if those two are there, and there's a sensory disability, you would be placed under multiple disabilities. So it is a little bit confusing. You can have multiple categories under your IEP. Only one is usually the primary. And it shouldn't matter too much, but it can matter depending on where you live, what the primary is in terms of what services are offered. For instance, in some places, if your primary diagnosis is autism, that assumes that you actually don't have physical disabilities, so physical therapy might not be part of your IEP. So it is really tricky, and this wasn't developed with SLO in mind, that's for sure. So even just thinking about strategizing about what the best primary category should be for your child is very individualized, and also probably matters in comparison to where you live and what things are out there. So the free and appropriate public education. Now, a lot of these terms are actually only important to use them because they're legal terms, in terms of if you're not getting the services you need, what terms you can be using. You're first yourself, and then, unfortunately, oftentimes with backup of advocates or other people to help you. But in terms of what is legally established, it is that services are designed to meet the individual needs of people as adequately as the needs of a non-handicapped person would be. I know that sounds a little vague, but what it's saying is that your child's needs should be met by the school. And that it's free. You shouldn't be having to go to a private school and pay for it, and appropriate. Now, appropriate, it gets a little sticky because what a parent thinks is appropriate is not necessarily what the school thinks is appropriate. And then the other term that can be thrown out there, which along with the free and appropriate education, is the least restrictive environment. And this is really important and really powerful that it was actually put in the law that the child should be placed in the least restrictive environment. This gives you the leverage, if you feel like your child benefits most from being in the least restrictive environment, to be placed in that situation. So it's to provide access to typical peers, and again, the emphasis is on appropriate. So just so there are some, since you might not do this research yourself, there's been some cases that have brought out some of these issues. So here are some of the cases, and that the things that are sort of considered in defining the least restricted environment are the educational benefits of integrated settings versus being segregated, and there certainly are many educational benefits of being integrated, of having exposure to typically developing peers, to model, to be involved, to even help teach, and the non-academic benefits, social interaction, in terms of social being just as important for adaptive functioning as academics in a lot of ways. And again, the effect that a student can have on the teacher and their peers is important. And then they do have to consider, obviously, the cost of supplemental services that would be required for a child to stay in the integrated setting. So these are sort of the options in a very coarse way. Obviously, the child can stay in a general education classroom with minimal support. It could be just bigger font on their worksheets, or someone coming in and looking at it a little bit versus just partial mainstreaming inclusion, where the child is pulled out, versus being in a full-time special ed class versus being in a special ed program that's outside of the regular school system. And then there's reverse mainstreaming, which I think is thought about less, which includes having typical peers go into a special ed classroom. So just going a little faster. These are the sort of the hierarchy that I was just talking about. And most of them are under an IEP, but some of them might be under a 504, which I'll get to in a minute. So in terms of IEP goals, and this is where these books can be really helpful, is because having good IEP goals, and what good means we'll talk about, is essential, and it's what protects you and your child from actually having what you feel like is important be taught, and that there's actual accountability for that, so that they're based on the child's present level of performance, which is where reports from outside sources can come in. Because you probably do want multiple eyeballs on your child to not just the school to be seeing what the child can or cannot do. You know yourself, but you probably want to base it on some other people's input as well. And that it's realistic, that you're not asking for an 8th grade reading level next year when the child isn't identifying letters yet. And we've seen, anything I'm saying are things we've seen, so that there be a realistic nature to them. And then the most important thing is how they're going to be taught. And this is important for a lot of reasons, because first of all, you need to know, and second of all, you should probably be involved. So if they're learning phonics in a certain way, then you should know what that is so that you can be reinforcing it at home as well. And you can be seeing if the child is working on these things at home. Or if it's just working on the B sound versus a different sound, that's important to know too, because if they're making the B sound more, that's really important. And then really, most importantly also, is what constitutes completion. How many sounds is a child making in their speech therapy before the speech therapist is going to move on to a different? So this is just an acronym of that people are using to help them think about being smart, using this rubric to help them. Everyone hanging in there? Nobody had a question yet, so I'm assuming I'm answering all of your questions right now with what I'm saying. So due process is the least fun thing to talk about, because it's when you're not getting your needs met, what you need to do. But it is a formal way, and again, these books and websites and Rights Law have a lot of information about what you can be doing to file a due process, to make a complaint formal. But before doing that, these books really talk about taking the steps to be involved as much as you can. I understand that schools do not want tons of involvement from the parents, but in a helpful way, being as involved as you can, calling meetings, asking the questions, setting the IEP goals so that these things don't need to come in. I know I'm talking about academics, but these goals can be also about G-tube feedings. They can be about speech and OT and PT just as much, and sometimes more so. It needs to be about those things too, about one-to-one aids, about whether nurses need to be involved. Due process should be available to you for those things as well. So I mentioned 504s. They're just when there doesn't need to be full special ed, but more accommodations, just knowing that that's out there, and this is the difference between them. And then behavior. So we've been talking about academics and other needs being met, but behavior is something that certainly gets in the way of all of this, and the schools should be addressing and can be addressing directly on the IEPs, because behavior affects the ability of a child to be educated. And so if you don't have behavior goals on your IEP, they can be added very directly. Sure. No problem. And so they can be just laid out on the IEP, but then also if behavior changes and you feel like behavior is interfering more with IEP goals, you can ask for a BIP, a behavior intervention plan, to be instituted at any time. And in order to do that, sometimes they need to bring in experts in behavior to do something either called a functional assessment, where somebody comes in and says, if your child is having behaviors at school that they're not having at home, then there's a reason to call in someone and have a behavior assessment to be looking for precursors or triggers of those behaviors that are happening at school that need to be addressed. And you should be not only privy to the plan, but very involved in it in terms of that we all know that a child doesn't need just one behavior sort of management system at school and at home, but that there needs to be communication so that you can be following through at home as much as possible. So, so again, the functional behavioral assessment, of course, that's only in an emergency or changing situation where we need something addressed. But what we want to be used and placed in the IEP in the first place is positive behavioral supports, is using praise, using whatever's motivating for the child as much as possible, whether it be their, an object they can mouth or whatever it is, should be in there to prevent the need for there ever to be a BIP. And then I did extended school year can be extremely helpful for patients, for kids with SLO, to make sure that there isn't loss over the summer. I know these things are really hard to get. And then I did just want to talk about diploma versus certificate, even for the very young children to be thinking about in terms of not necessarily that these are options out there. For some people, it's really important to think about the timing. After elementary school is often a time that things are really reevaluated in terms of certificate versus diploma. But this just lays out for you what the actual differences are. Your child should be receiving maximum services to maximize their education regardless of whether they're in a diploma or certificate-bound program. And then transition services. I know I'm trying to gear this towards preschoolers, but by 16, there should be a full plan for transition services in place, at least the idea of it, because it's not fair to parents to have it to be looming over their head. Even if we know that it's going to change, it just can't be this black box that nobody's talking about. It needs to be something thought about early. And it's okay to ask questions, even in elementary school, about where you see this child going. I know it's not easy to hear, but in terms of starting to think about what's out there in your community, we know lots of families have moved, and so to be thinking about, far ahead at that point. And that is where I'm going to leave it here. I know it was very broad strokes, but I just wanted to make sure parents who have very young ones have this sort of big picture in place. But I know there's hours to be said on each of the topics I brought up. So I will end there, and happy to take questions now, later. Some of you already know how to find me other times too. But thank you for listening so early in the morning.
Okay, you had made a mention about the behavior plans.
Yeah.
Okay. How would you suggest a parent handle it if a child is exhibiting behaviors at school? We'll use headbanging. A lot of SLOS kids do that.
Yeah.
Mine doesn't headbang at home. We had an instance at school where he was headbanging. They wanted to just put a helmet on him, and I didn't like that idea. It made it worse. And like you said, there has to be a trigger. If this is not happening at home and this is happening at school, there's something at school that is setting him off. Do you have a suggestion on how to get them to work with me better, other than sticking the helmet in his backpack and sending it home?
Yeah. I mean, I won't address the helmet so much just because if they're worried about the safety issue, but clearly to make it so you don't need that is the issue. So that is exactly what these things are for, to ask for a behavior intervention plan, but especially ask for the functional assessment. And if they're not bringing in outside people, they probably need to be, because it's hard for the staff themselves to be seeing what they're doing. They cannot do their own assessment. They really probably need to bring in outside people to be looking for what the triggers are. And it can, as we know with these kids, it can be a sound 2 rooms away. It can be another child. It can be, they need lunchtime to be earlier. It's not necessarily the academics or what they're working on. So it takes a lot of eyes to be, and ears to be thinking about it, but this is exactly what a functional assessment is for, and I would push hard for it.
Thank you.
Hi, I have more of a comment than a question, and maybe you can back up what I'm saying. I have a 16-year-old, so we have been through the early process, and I know that some of the evaluations, initially when they gave her the evaluations, we had to push for the autism evaluation, because we really thought she was showing atypical autism behaviors, but definitely the communication, the behaviors, and things like that. She's very affectionate, so we were told initially, oh, she could not be autistic because she hugs and she kisses and all that stuff.
I didn't put affection on there because it's not on there.
Right, so, you know, we had to sort of push for that. My main comment, though, is for the people with younger kids. Not only the evaluations you get and the diagnoses you get can not only just affect their schooling, but it can affect the rest of their life, because with just an autism diagnosis in our state, you get very limited resources in terms of job training and living space and things like that. But with an intellectual disability diagnosis, doors open up that they wouldn't for autism. So as a parent, it was very hard for me to hear the intellectual disability diagnosis, but I realize now it was probably the best thing for her.
I feel like I planted you in the audience because
We don't know each other at all.
because right now, I have slides I can show that in school systems, the diagnosis of autism has gone like this, and the diagnosis of intellectual disability has gone like this. It has gone down, and that is partly, it's all of our fault, but it's because we're doing autism evaluations and we think that the word intellectual disability is bad.
Right.
It does sound like it's not fixable as much as autism feels like it's fixable. I mean, and so we have, even when it's very obvious the child has the diagnosis, we are avoiding it. School systems are avoiding it. Outside providers are avoiding it. But
See?
that's why I showed the criteria, because they're really not that scary when you look at it. It's about what the child is doing and functioning, and the services are to help people make sure that they get the help in the functioning that's needed. So I couldn't agree with you more.
And the best thing somebody told me is, it's nothing different about your child. It's just another label. Your child is who your child is. They've had this all along. They're just getting a label that might help them in the schooling or in the future life. So.
But we need to move the needle. All of us need to help in doing that.
To comment on, to piggyback off what she was saying, we were told by our advocate in California to have autism first and secondary is intellectual disability, because teachers and staff will give up on our children with the intellectual disability. And in California, you get the services. Doors open up when you have autism, especially the crucial ABA therapy.
Yes.
So with having that, it opens up doors for therapies, and to get it funded. That's the biggest thing, because
Yes.
it's so expensive.
And it is true. I don't know what state she lives in, but I understand that California has these issues. I actually have a friend who's working with the legal system in California to change that, and I can give you their contact information, because people are working on that right now, because California is where ABA started, and there's documentation about how it started for intellectual disability, not autism, but that sort of got lost in the shuffle. All right, I don't want the next speaker. I want the next speaker to have all of her time, so feel free to come up to me later, and thanks.